We are recording.
Well, welcome everybody to the GW Neurological Sciences Grand Rounds. Today, I'm very delighted to introduce Dr. Aline Herlopian from Yale University. Aline and I first crossed paths in Cleveland when I was at Case Western. She was there for an elective, I believe, and it was evident from the get-go that she had the willingness and ability to shine in the world of epilepsy. Aline is now an associate professor of neurology at Yale. She has completed her medical school at the American University of Beirut and then did her residency at the University of Arkansas before pursuing her epilepsy fellowship at Mass General in Boston. She joined Yale as a faculty member in the Yale Comprehensive Epilepsy Center, where she is also the medical director of Yale EEG and Clinical Neurophysiology Lab. Aline also directs the clinical trials in the epilepsy division at Yale. She's also a faculty affiliate of the Yale Institute for Global Health and is highly involved in a collaborative work to enhance epilepsy care in Armenia. Her primary research focuses on studying high-frequency oscillations as both hub and network in terms of their association with the epileptogenic networks and their predictive value in determining surgical outcome. She's also investigating the role of thalamic nuclei in ictogenesis, ictal propagation, and seizure termination. She has many peer-review articles that have been published, and she has authored also a book called Epilepsy Surgery, a Practical Case-Based Approach. Welcome to GW, Aline.
Thank you so much. Good morning, everyone, and thank you, Dr. Kubaisi, for this generous invitation today. As Dr. Kubaisi has mentioned, I'm going to talk today about high-frequency oscillations and from a network perspective, and how can we study them in the field of epilepsy. Those are my disclosures. And so what I'm going to start is just to lay the foundation of the talk is how do we define high frequency oscillations? How do we record them? And this is critical. Those two steps are very critical because it will help us later with analysis and devising our future perspectives on this. So how do we define high frequency oscillations? I was last year attending the there's this international high-frequency oscillation workshop that's done every few years, and it was at the NYU last year. So what they did is basically you would see all the world prominent figures who are working in the field of HFO and annotating them or creating the detectors. Just were sitting there and we're trying to create a survey of do they agree upon certain patterns that are high-frequency oscillations versus not. So what I did as a courtesy from them as well, I posted some survey results for me to show the audience that despite the fact that we have certain parameters or measures where there is a consensus of how do we define it, that said, we still have this very big disagreement in identifying high-frequency oscillations. For example, let me start with this example. An intracranial study, you see it, this is the raw data on the left, and on the right, you have 3 panels. The bipolar EEG shows a nice spike, and then there's this fast activity there. If you filter it and stretch it out, it shows this. I voted this as this is an HFO, and you see it here on the spectral analysis, like the lower band, like the power in the lower field, and then you have this higher power here, which is this spike there. So my vote was among the 52.17% versus 41% who said this is not an HFO. And there was like 7% who were not sure. This is the second one, which technically I voted this is not an HFO, because if you look here, this is the upslope. The question is there an HFO overriding this upslope here? And you can see this whole power here in the lower band, and then you have a high power signal here on the higher band. So some people, based on this spectral analysis, they voted that this is an HF4. However, looking at the raw data, for me, this is not an HF4, and you see it from the scores. 54 said this is not an HF4, 39 said this is an HF4. This is a scalp EEG where you have a high concordance rate among voters, where you see here, there's in the raw data, there's a spike and then the slow wave. And then if I show it here, there's this cap on the spike part. This is a stretched out. And then if it's filtered, you see this see it's more than 4 oscillations. It has a nice peak, high frequency. If you filter it more than 250, it doesn't necessarily stand out much as it stands out for the ripple range. And most 77% voted that this is a HFO. This is voted also as an HFO here. If you look at this channel here by itself visually, one might say, oh, I don't see any HFO on that channel. However, if you filter it, this is the unfiltered, but if you just sort of like magnify it and you filter it, you would see a very fast ripple in this region. So this was marked as an HFO. And this is the hippocampal low filter potential, where you see it just overrides a spike here. You have the high power in the, like an island. It's in the 350 and between 300 to 400, and then you have this nice oscillation. So what's an HFO? How do we define it? Keeping in mind the variation among people who sort of I describe an event as an HFO. First of all, the key is, and that's also built in detectors for HFO, is the amplitude. So you have a baseline activity of the brain signal, and then you have a % change in amplitude that should be sustained and should last for a specific duration. That amplitude, as you see here, it's a broad amplitude, and the amplitude is not a monotonous amplitude. It just has the variations in it, in the oscillations. So you have to have a higher amplitude than the background. It has to have at least 4 oscillations. The duration for the ripples are longer, ripples are shorter, but that's not a criteria for exactly saying, oh, I'm marking this as an HFO based on duration. It's probably one of the criteria where you would exclude after identifying an event. You have to have at least a minimum of 25 milliseconds between 2 events for you to say this is an HFO. And the other part is you have to acknowledge the variation in morphologies, as you have seen earlier. Plus, there's one caveat that we have to keep in mind. We often see in the papers where they talk about ripple, fast ripple as a dichotomized category. They're not as such. You might have a ripple that's a combination of gamma ripple, fast ripple. You can have an ultra fast and a fast ripple. So it might come with combinations. So it's not necessarily just one frequency range. So why is this important? Because of our detection of those HFOs. So how do we detect them? So there are a few ways of detection. At this time point, we rely on predominantly automated detectors and visual detection. Visual detection, very straightforward. You take the intracranial EEG, expand the view, you get some channels, and then you put your filters. Let's say low frequency pass is the 100 to 250, and then you start marking the HFOs. That's time consuming, and it might take for one 30-minute intracranial analysis, it might take you up to a week for you to completely annotate a 250 channel intracranial monitoring study. So that's why we have the automated detectors. So the way it works is basically you extract whatever you have, let's say, a platform you have to use for the EEG files. You extract a clip from that file, you export that EDF, and you use that EDF into pre-processing, and then you start analyzing them. When do you mark those files? What clips do you use? Typically, we use an N2 stage, and I'll show it to you why. You would use the farthest from the seizure, but I use it 4 to 6 hours. Some people use at least 2 hours. You have to pick a place where there's least artifact for you not to have increase your chances of false positive. And the question is, how much data do you need? Like, is 130 minutes enough, or you should get 5 minutes of the whole night? So there's lots of variations in that. However, I would say 20, 30 minutes of a data file should be enough. And then the other modalities are the approach, the methodology of sort of annotating those HFOs would be as such. Either you have visual detection, meaning you just do nothing in your life but identified visually those HFOs, or you use multiple automated detectors and get a common identified detections, which means you're decreasing your sensitivity, increasing specificity, and or you have, let's say, which they did for the intraoperative electrocorticography, you do automated detection and then followed by visual annotation because the files are already short, small, and you have limited channel sets. Some people might use their own channel detectors from their centers. So I'm going to show you, this is a variation, possibilities. So if you see here, those are all, let's say, this is the sensitivity curve, you become more sensitive, and then this is the specificity. So this has the least sensitive, whereas visually you're detecting. Those are all visual detections. And as you see, there are not that many. Here in the second one, what you're doing is you're adding also automated detections, right? So you have more events captured. Your visual annotations are still the same and they overlap with whatever you have detected. For example, you have the detections here and the automated detector, you have one here. So all these are already detected by visually. But then you have the others that are not detected visually. The automated detector has picked them up. And then the other one is where you use another detector that has a very high sensitivity and just detects everything technically. So the variability, and the reason why we spoke about why is it important to get multiple samples, because if you see, this is like a 5-day study, and it shows on different channel numbers the variations of the high frequency oscillations, and the power is described by HFO per minute, the rate of the HFO. If you see here on day 4, you have a higher power of HFO on day 4 on channels 60, technically 50 probably. Here you have a bit on the 30, and so you have a lot of HFOs in these regions, less on day 3, day 2, you have a bit more on day 5. And as you see here, those channels are the one that are identified as a seizure onset zone, and the other is the resection volume. So this is a single duration, which is about, let's say, an hour or so. And you see, look, this is the variation of the high frequency oscillations within the seizure onset zone. And then you see in the non-seizure onset zone, how does it vary? So there's lots of variabilities in this. That's why it's very important for you to have enough sampling of a data and not just go by one time point. This is when you have seizures. As you see here, the bars represent the different channels, channel 1, 2, and 3, and those are the different days. On day 6, you have seizures, and the seizures start on day 6. And as you see, the high frequency oscillations tend to cluster more around the seizure types. So that's why it's very important, if you're studying high frequency oscillations, you keep this in mind for you not to bias your selection towards only those sequences or the HFO events that are clustered around the seizure onset zone or like brought up during the seizures. Now, coming to the detectors, what is the best way for us to identify, like, which detector should I pick? Which one should I use? There's a lot of detectors out there, commercial, institutional generated. So what you have here is for those detectors, basically, this was a poster presented in 2013. Maltseva et al. They used 11 detectors, and they tried to compare those detectors with their own patient sets and try to identify, is there a difference between any of those? So basically, what there was is overall, intracranial, the data is for both scalp and intracranial. For both, the HFOs at a group level was able to identify, the detectors were able to identify HFOs generate that are most active and sort of are in agreement with seizure onset. So that was, the agreement was there, like the highly, which HFOs are most active, which channels are most active. That was detected correctly. But at an individual level, there was wide variability. And as you see here, the agreement between different detectors varies. Now, in the intracranial study, you would see that the blue line represent HFOs, HFO without spikes, and you have the green, which is the spike HFOs. For intracranial study, agreement for the detectors was higher when they were detecting spike plus HFO versus HFO only. That's for the intracranial. For the scalp, first of all, the agreement was better for scalp HFO detection versus the intracranial. You see here, there are low number ones. Those are very low, for example. And then you would see here, those are technically the higher numbers and only few that they had like low numbers. So for the scalp, the agreement was higher for HFO occurrence versus spike HFO occurrences, like detection. So that tells you in a nutshell that that's why we are trying here in our center at Yale, we're trying to sort of try to figure out, should we use combined or enhance certain detectors, or should one detector suffice at this point? I'm just going to give you a case. This is a patient and 36-year-old at time of the surgery. Seizures started at the age of 4 years, right hemispheric non-lesional epilepsy. Seizures were arising discretely from the HD1, HD2, which is technically the head of the hippocampus. Those are the two contacts. Patient underwent right temporal lobectomy and seizure-free at 2 years. Path was reactive gliosis. As you see here, we have a broad coverage, right? With grid, strips, depth electrodes. So this is an extensive coverage that would show you nice HFO. So if you see here, those are the visual annotations. So this is how you expand it. So see how you have to expand your view for you to have to visually see the HFOs. You see it's more than 4 oscillations. And this is this waveform where it overrides, there's a cap on top of it. So that's the high frequency oscillation. So this is a spike HFO. This is another HFO where you would see it here, and then it just like translates into this nice, as you see here, the morphology is different. See how it's different, the morphology, so they have different morphologies. So this is the Ripple Lab, the one that we're currently using. It has 5 sets of detectors. So what we do is, if you see on the right, the way it does it, it's a great tool to use it. You have this event detection. So you feed one channel, and it starts detecting all these. So it has high sensitivity, 353, and it gives you all the raw data. So you can visually validate and exclude which one you would like to see. So for example, what I do is also, we go back, for example, this 1023, you go back and you look at the other one, you'd say, okay, look, it's the same here, probably this is true. And then that's how you start sort of taking the common detections and try to put a threshold of your detections. This is the MNI detector. This is the short line length detector. As you see here, there are 3 detections versus 353. See the variation in detections? And then this is the short line length detection. This is Avo Sarkisian is one of the visiting students here. He's working on our automated detector. So those slides are provided by him. So this is, again, another Hilbert detector. Just in a nutshell, the way these detectors work, basically what they use is there's different parameter settings, thresholds to say. They all rely on amplitude when they detect. However, it's just the thresholding or other parameters that they add to these detectors where they sort of adds to the complexity of what you're detecting and how you're detecting. So that's why I believe that if you use multiple and then you can just filter through, that would be the best. This is the MNI detector, the one recently. This is shared by Dr. Goldman and Nicholas Volender. If you see, this is different than the one in the Ripple Lab. You have up to 427 detections. So coming to the analysis. So now we have established our methodology, which is technically few automated detectors plus visual validations. We're going to walk into the analysis. So I'm going to talk more on how do we see HFO as a network. anywhere from the late 1990s until around 2000, probably 15 or 2020 or so, most of the data, if you see, they're all concentrated on HFO rates. HFO, or let's say ripples, isolated, fast ripples, seizure onset zone. They talk about this different entity, spike HFO, but no one technically took it into the level of, do HFOs organize? And then when I say organize, means like, do they cluster and do they sort of move, like propagate? Now, there is also in the literature, I want to highlight this, there is still, I don't see a clarity yet as, should we call HFO propagation? Do you call HFO clustering? Do you call different populations of neurons firing synchronously? That's why you see this whole network coming up. I'm unsure about that. That's still not that clear. However, visually looking at those, we have these these channels, for example, let's say, they start with one HFO, and then you see within certain milliseconds, at least 25, they just like propagate, and they just like have other HFOs from different channel. And that's how networks are constructed now. So most data now, most analysis now are being done, not only did I remove high rates of fast ripple, did I remove areas or zones that have ripples, fast ripples, spike fast ripples. No, what they're doing is they're saying, okay, we did not find an answer for those analysis. Let's look at it as a network level. Like, do these HFOs do anything on network level? And that's why other network spatial and temporal measures have been incorporated into the analysis for them to say, okay, this is what we're seeing. I'm going to talk about a few papers, and I think those are good representatives of what's being done as a network analysis mode. So one of them is from the team at Boston. It's Tamilia et al. And they work both on intracranial and scalp pediatric epilepsy. And this is a paper where they looked into what is a what is a network, ripple network, first of all, and then does the ripple network impact surgical outcome? Does the ripple network have a consistent onset of a channel that drives the other? Or is it important that we look at propagation of the network, the onset of the network? So basically what they did is they constructed a network, as you see here. It starts channel 24, let's say, and goes down. Here you have another network, and those are contacts. As you see here, this is the power analysis of it. As you see, this is the unfiltered, and this is a spike over HFO here. And those are the contacts where you can see HFOs are coming from. And this is the latency, meaning the onset is here, and then, or it's here, and then it propagates to other areas. So I have one sort of comment on this, is that typically for HFOs, for example, how do you know where the onset is? We don't have an exact definition of how to identify the start of an HFO. And if you see here, this is, they identified it as the propagation onset. So I'm assuming, could this be the onset of the HFO? When I visually mark it, I use the first oscillation that technically disrupts the background, like the baseline background, but that's hard. So that tells us that even with the detector, when you're identifying the first one, you will have variabilities. So this is other representations of how the HFOs are propagating. And as you see here, those are those color maps. They use, basically, they show you how it propagates, and it starts and then moves around, starts and then moves around on the grid. And you don't necessarily have to have like a specific propagation. And that's the other caveat as well, that even in our analysis here in our center, we don't limit or constrain the analysis of HFO with spatial constraints, meaning we just like sometimes take it out of the analysis just for us to not exclude or not to add a bias to our analysis. And if you see here, this is a graph that shows you that this is a patient with good outcome. This is a patient with poor outcome, which is not seizure-free, not seizure-free. And it looks at onset ripples, which means the channel where the ripple started and that led to the emergence of the others. And this is the spread ripple, which means those are the other contacts that were present during the ripple network, but they're not the onset. So if you see the blue, the purple is the resection. So you see in the poor and the good outcome is that the good outcome had the onset ripples resected. The red is the onset, and the ones here that are outside the resection cavity. So that tells you that with the pardon me, sorry. Okay, so that tells you that the onset ripple was important versus the spread. If you see here, you have it spread to different contacts, but that has minimal resection versus in the poor outcome where you had most of the propagation resected, but not like and involved the spread ripples. So their outcome was that onset ripple, resection of the onset ripple are the ones that are predictors of outcome. And this you see here, this is the latency, this is it, as you see the box plot here, this is significant. So technically that tells us that the latency inside the resection, like how close they are to the onset ripple is very important. And this is outside the resection, it's technically pretty close. And then if you look at here, the onset ripples are the ones that are associated with the good outcome. This is the inside the resection, which means if the onset ripples are included within the resection cavity, then they have a higher chances of good outcome. And for the spread ripples, there is no significance, and isolated ripples, meaning solitary events without networks, they also don't have that outcome. This is another paper by the MNI where you see here different ripple networks, and they constructed different networks for HFOs, and those are different variations. The darker color is the one that has the highest rate of the HFO, and they can spread out. Again, as a comment, for me, when I analyze these things, I do acknowledge the limitation of us not knowing which is independent or not, meaning you have LCM and you have LFS. Even if those are, let's say, close to one another on a grid or on the brain, how do I know that those are synchronized? That's another word that there's like this debate upon. Is it coupled, synchronized, independent? How do I know that there's the same mechanism that's making these HFOs pop up in a specific sequence order? And how do I know that these are not a matter of random effect? So that's why you have to have high set of data, meaning high count of these sequences for you to sort of try to address that question. This is the same, like if you look here, there's LA, and this is the amygdala, the hippocampus. You have here the ILH1. So they constructed these networks, these different networks, and they found out that so basically what this means is this is like non-source channels. Basically means that those are all the ripples and non-ripples, all those channels that have ripples and non-ripples, and in the propagation pathway, this is the onset of the first contact that comes as the onset, and then this is the rate number. So there was no difference in the seizure onset between any of those in terms of outcome. What basically they have identified is that they said, okay, we do see a pattern. We do see a pattern that there's a sequence. However, resection of the first contact of the network doesn't lead to a better outcome, nor the network itself. What they found out as is the rate of which is this one, has source, which means like technically it's all of the channels. If you resect those versus the first source, those are the ones that are going to have the better outcome, technically meaning that if you resect contacts that have a high fast ripple rate are the ones that are going to have a impact on the surgical outcome and not the resection of the first contact channel of the network. This, we're going a step further into using more of advanced modalities into understanding HFO networks. And that's what I think the studies moving forward in the past few years have been doing. So what we do now, this is by Waste, and now they have like pretty nice data coming in the data published in the past few years, and they talked about using theoretical measures to understand ripple networks. And actually, they have concentrated mostly on fast ripples more than 350 hertz per their data of looking into those ripples that are truly important for the epileptic network, and try to either study if they can predict outcome or not. So if you see here in the first graph, what they did is E is angle, RR is the resection cavity, the resection ratio. So basically what they said in the angle 1, angle 2, 3, or 4, you have high rate of, let's say, resections. The resection ratio of the seizure onset is high, and you have the better outcome versus here, but you don't have much of a difference in the median. Here is the same, the radius, like how big is your seizure onset radius. And this is the unresected radius. So there's not much difference between those parameters, basically like seizure onset radius, the ripple within the radius, resection. So there's not much of a difference. And this is the fast ripple frequency. This is the unresected, this is the resected, and this is the violin curve. So angle 1, 2, 3, 4. There was not much difference even here. Like if when you look purely at is the resection of as much as like contacts that have higher fast ripple rates, if I resect them, does that impact outcome? The answer was no. So they didn't find that in the utilizing just fast ripple as a single parameter itself. So what they did is they said the following. They said, okay, we do see those HFOs as network, and they come organized. How about studying them using two measures, spatial and temporal? So what they said is the following. Instead of them using just solitary events as rates, just to use different measures. For example, the fast ripple rate distance radius. What basically this is a theoretical measure where you use, let's say you have a fast ripple network, the entirety of a network spans from point X to point A to point, let's say X, and then you resect part of it. There's a part that's left unresected. So you take that unresected part, press the resected part, and you weigh it based on the rate of the fast ripple. So you come up with a measure. So if you see here, those people who had angle 1 had the score of the ratio was significantly impacting the outcome versus angle 2 and angle 4. So that tells you that when you're analyzing HFO, you have to add not only, let's say, the same way we now look at epilepsy, not location like focus-wise, we look at it as a network, that's the same thing. So you have to look at it as a whole network of the fast ripple and how it's being resected. So that's here, the angle 1 has the, shows you that those who have the seizure freedom, they had the higher resection of that ratio within the fast ripple network. Coming to the temporal measure. So the temporal measure technically tells us that what is the distance? It has three parameters. You have the path length, the clustering coefficient, and local efficiency. The path length is what is the length between nodes. The coefficient, clustering coefficient, is the degree of each node within that network of the fast ripple affecting the other. And the mean local efficiency is basically, it's the inverse of the path of all the neighboring nodes compared to that single node. So those are all temporal measures. So basically what you look at, what you see is the path, the distance, is the longer the distance between the nodes that are resected, that's better outcome versus here. So if you have closer nodes to the resection node and that close neighboring node is unresected, you have a poor outcome. The maximum clustering did not have much of an impact, and also the mean local efficiency. However, in the mean local efficiency, if you look at this in the unresected network, means that the higher the mean local efficiency of unresected nodes in the network is, the higher you have that. And so technically, this is what it means. If you have a node that is disconnected or isolated from the other neighboring nodes, and that node is disconnected, then you have a better chance of a surgical outcome. So those are the temporal measures that they utilized for them to come up with these HFOs. So if you see here, this is a seizure-free patient, and this is not a seizure-free patient. This is basically the MI model. What basically this shows is the following. See the yellow dots here? That's the resected area. The red are all the neighboring contacts. So what it means is you have a disconnection, means you have a low score of MI compared to the neighboring. So this means that those are isolated. If I cut them, this will go have a good outcome. This, however, is the contrary. The weight of these yellow nodes that are resected is so high. This means that there is lots of impact of these on those, on the others, and they're tightly connected. See how the connections are? Those versus those connections. So that's why if I resect this doesn't necessarily will lead to a good outcome, because the connectivity of this to this, they are connected to one another. They're not dissynchronous. Now, how can we translate this clinically? I think this is our step moving forward, where we have to look at the HFOs. So this is the last network paper I'm going to talk about. This is from the UMISH, and those are patients who had, this is again, network as the Ripple network. So what they did is they said, okay, we have the HFO rates, but that's not technically telling us much about the surgical outcome. Then let's use other network connectivity measures. They use the eigenvector and outcloseness centrality. So basically what this is those are measures that technically tell you how strong or how impactful a node within an HFO network is compared to the others. So what they did is their outcome was the CREP, the critical resection percentage. What they did is they used all those HFOs, and they came up with a model where they said, okay, those HFOs that have certain measures, meaning high rate, higher connectivity measures like the eigenvector and the centrality, if those are resected by 30%, they will have a good outcome. See, those, if they are resected, they will lead into a good outcome. So that's how they analyze these. So if you see here, so this is the centrality. Flan out means how fast it's propagating outward. And those are the ULAN and the FFCN is how tightly those networks are correlated. And this is just a simple HFO rate that we use it. So if you see those patients, A, B, and C, those are all patients. This is who had good outcome, which means definitive surgeries. And then this is the palliative, which is like those who did not do well, perform well. The measures of the network of these two patients, A and B, are significantly different than C. However, if I look within these measures, I see that the centrality, the flan out of the definitive was way significant than the other measures. So that's how they started to look at these measures. And those are the people, if you see here also, the resection. So if you see the resections here, and all patients' definitive surgery is way different in terms of network measures compared to those who are palliative surgery. And the blue is the class 1, which is the good outcome, and the 3 is the poor outcome. So there are network measure differences between those who have definitive surgery or all group patients versus the poor outcome. So I'm going to show you a different example of what we're doing now in our lab here. So basically an example is, this is another person who has right-sided epilepsy. We did intracranial monitoring, and this is the mapping here. And then as you see here, those are the HFOs visually identified. And those are also consistent with the automated detectors. And then here you have some sequences combined together. And then, so one of our lab team members, Levon Papikian, he is now looking into the dynamics of those HFO networks, meaning in the past, we had looked into the dynamics of people who have just HFO rates. Now we're looking overall as a network level. And if you see here, we have the sequences. Those are the ratio of the sequences. When you have the highest meds, they are suppressed. And when you have the lowest meds, they're just out. There is one caveat to it. We did not factor the seizure occurrence during this. It's just purely low meds, high meds. This is seizure onset versus non-seizure onset. You see here the dynamic changes and the duration of the sequences. We're also looking at how the duration of the sequence varies over the days according to medications and low medications. We are seeing at an individual levels some variations. However, we have to look more at a group level. Plus, we have to look more into different parameters such as the location, pathology type, seizure duration, seizure type, seizure networks. This is another way of looking at the sequences. As you see here, this is the Yale Brain Atlas. This is recently developed, and we use the brain parcels and overlap the intracranial contacts with them. So each parcel has a name for each patient to overlap the HFO sequence. As you see here, those are all the seizure. The pink ones are the onset, the purple and the green ones are the propagation. This is the resection cavity. And then the HFO clusters, they change over the course of the recording, but they more or less overlap with the resection cavity. So that also we're studying it, and we're trying to identify how these sequences, what are the measures of these sequences. This is by Meghna Shamarty as well. She is trying to look at the flow of the HFOs. How do they flow? Meaning she uses adjacency between those parcels, and she tries to identify how do these networks move towards. And she found out that when these networks move, there is, if you take out the parts that are the seizure onset zone, so these flow of the networks are disrupted. So here, so this is the flow rate, for example, let's say on this is the single patient, different days of the patient, and then you would see the max flow. If you remove the parcels that have the seizure onset, they will have, or the parcels that have the maximum flow, the flow of the HFO is going to be disrupted. Versus if you randomly remove parcels, which is not going to disrupt the flow. So that tells us that the seizure onset and the HFOs are linked to one another. This is the curve that shows that. And then this is how the flow changes over the days on the, again, mapped on the brain parcels. So significance, coming to the last part, what is the significance of what we do now for these HFOs? So this is the latest, I think it was a review, systematic review and meta-analysis. It looked at all the studies that looked at resections of HFOs. Again, they're looking at contacts, not networks as a network HFOs. And then what's favorable outcome. So you have 31 studies combining between peds and adults. And then you find here where, if you see here, the area under the curve here, you would see that the likelihood of favorable seizure outcome was higher for those who had removed the area of the complete resection of the HFO area versus not. And this is the paper by Jacobs et al. Who he refuted this, and it falls on the lower end here. And then this was applicable for both the ripples and the fast ripples. Now coming to the, I'll skip this one. Now coming to the lobes, basically, does the lobe matter? So they tried to adjust for all the variables, and they found out that we can talk more about favorable outcome in extratemporal lobe epilepsy when we remove those HFOs versus temporal lobe surgery. And that still remains to be explored as why. This is the HFO trial where they randomized people intraoperative ECOG to HFO guided resection and non-HFO guided resection, and they found out that they looked at pathology. So they said, okay, we're going to now adjust for the pathology and see if HFOs trump the spikes. And they found out that in extratemporal cases, they technically are the non-inferior, and they don't do well in the temporal lobe cases. Again, there are lots of variables here that needs to be assessed and measured. So what's our future? So as I was mentioning during our talk, we have a lot of limitations. Number one, we have to start getting consensus. It's nice to have expert opinion, and but it's good to have at least some consensus on what an HFO is, because that defines our detectors. We build detectors based on what we believe an HFO is. And as we saw, there's not much of if you can use you have 11 detectors, but none of them is better, outperforms the other. So that's where the solution was you can use few of them, get sort of the common detections and use those. That will remove lots of other detections. So the question is, does machine learning help? EEG feature extraction. So you could use all this data that you have and you dump it into those learning models, and they try to do EEG feature extraction, you train it, and then you revalidate it. That might be an option. And then after that, you sort of start to learn how to get a consensus. Might that be a way of doing it? That's a possibility. The other one that I did not highlight is none of the papers talks about physiologic versus pathologic. Meaning, if you have a seizure onset zone in the occipital lobe, right? I mean, most of the papers, they were all temporal lobe cases. But what if you have an occipital lobe seizures or an epilepsy? How do you know this particular ripple is not a normal physiologic ripple or it's a pathologic ripple? So that distinction is not present yet. And that's what I think one of the main limitations that skews or that makes our interpretation of results a bit challenging. And that's why I do think that we have to add more parameters into our definition of HFO networks for us to sort of counteract these limitations. And then the recordings. You have different papers using different recordings. You have the long-term, intraoperative ECOG, subdural SEEG. I don't like the SEEG when it comes to studying HFOs. It's so spaced out, and you have a lot of white matter. You just have few here and there contexts where you can analyze it. And versus subdural, it's very nice, comprehensive, and it gives a nice neocortical coverage. And then there's the better technology, which means we can sample a bit more. Again, heterogeneity, sample size. And then the last thing that I have to mention is, okay, we talk about those HFOs that we don't have a consensus. But how about the epileptic network? How about the hypothetical epileptogenic zone? Like, we know this is a seizure onset zone simply from a biased intracranial sampling that this is the first area of the seizure onset. So if you have a technically the deficient or inadequate gold standard to compare to HFO, so now you have two muddy concepts. You're trying to make something perfect come out of it. So I think that's why I do believe that adding more measures probably might help. And one good solution would be a multi-center study of homogeneous patients, meaning mesial temporal, path-proven X case, at least a good sample number of 50 people, seizure-free for more than 5 years, reduced medications, some group where we start from there and then move forward. That's what I think probably those can help us, because all those papers, if you look back, And that's why I sometimes do think about it when we think about HFOs. Like when I showed you the graph-based theories or the other network metrics, those are nice research-wise, but if there's a team reading an intracranial monitoring in your epilepsy monitoring unit, what am I going to go and tell them, right? Like, I'm not going to do centrality analysis on an intracranial monitoring patient who's now requiring analysis. So all these things have to be factored as, okay, those fancy stuff that we're doing, how are we going to translate that into a clinical application, something that truly would improve patient outcome? And that's it. And thank you so much. And if you have questions, happy to answer them.
You're muted.
Thank you. Thank you so much, Aline. That was very helpful to understand what happens in the kitchen of HFOs, before the papers come out and predict surgical outcomes and other clinically useful questions. I have you mentioned the physiologic HFOs towards the end of your talk, which is a very important subject. I think as epileptologists, we're very interested in networks and seizure hubs and surgical outcomes. But I think the body of work that has been done on physiologic HFOs is very intriguing as well, especially when it comes to their shedding light on cognitive disorders,
Mhm.
but also on brain-machine interface. This is something that is very, I think, hot subject these days. Can you mention a couple of words about um, your view on distinction between physiologic and pathologic HFOs?
So from visual annotation that I've done, and I would start just like visually, I pretty much get a sense of if this might be something benign versus not. Again, this is probably personal bias. Is because of duration and the way that it looks in terms of morphology. It's very modulated, long, and it doesn't have the peaks of frequencies, that needs to be studied. And the reason why I do see that is because with Dr. Spencer's coverage, where in the past, as you saw in the two of the intracranial monitoring, we had a great coverage of the occipital lobe, which has nothing to do farthest away from the seizure onset zone. So that's a nice way for me to look and say, okay, we're detecting those, and this is how it looks. So that's the visual analysis. Now, what we're doing now in the dynamic changes of these, we're trying to sort of sort it out based on lobe as well. And we're trying to identify if these sequences, they fluctuate, something happens to them. There was one figure, I didn't show it, but and it was something that was observed as well during one of a work from Netherlands, Van Klooster's group. Basically, what they did is they were doing an intraoperative ECOG. They resected the area, and then they saw ripples in the sensory motor cortex, new onset. Their hypothesis was, could this be that there's a disconnection between the seizure onset zone, like the seizure epileptic network, and now the physiologic network that was sort of enslaved or restricted or inhibited by the epileptic network? Now it's released and can do its function. We've seen that in one or two patients where we gave them passive motor tests and try to identify certain sequences. And the sequence of those patients, because we have the coverage of the motor cortex and the seizures were, let's say, distinct from that area, we saw change in the seizure in the network clusters of the HFO during those motor testing. Now, the limitation is there's muscle artifact. There is you're going to see those waveforms that you're like getting them is not like abnormally filtered signal. So those are the limitations. However, looking at those two people and one center who had something similar, that tells me as well, is there a pattern where we can utilize as motor testing or language testing or some form of testing, study that time frame and those analyze them, those features, and see what they look like. I think the machine learning era is marvelous because um, it doesn't have, it might have their own its limitations, but I'm not sure it's as biased as the visual or the automated detector. The detectors in itself are biased. You plan them. You see this way, you give it this way. You know, it doesn't learn, it doesn't correct mistakes.
Gotcha. Thank you. Um, are you aware of any reports that mention the effects of any other pathological conditions on the dynamics of HFO, such as like old stroke or trauma?
Hmm. We're trying to look at pathology type. That's why we're including path in our analysis. We're trying to look as does the dysplasia behave differently? Do most of our cohorts are either non-lesional, that they get the broad coverage, or lesional dysplasias where you do the motor mapping. So that's one thing that we're trying to look, does the dysplasia do something different than the other?
Mhm, mhm. Okay. And to go back to the novel signal processing techniques, besides machine learning, well, first of all, to talk about machine learning, do you foresee like a huge global bank of intracranial EEG, similar to what has already taken place, I think, earlier, but specifically focused on studying HFOs in order to provide big data for machine learning?
We have to do that. I think well, hearing those networks, when I was in the workshop, the HFO workshop, that was brought up. They did one single multi-center study on, I forgot the number of the intracranials they had. So I think, first of all, international endeavor is a must, and it should come from different countries all across the globe, because you have to get a good sample number for a homogeneous sample. If you're looking for temporal lobe epilepsy, mesial onset, 20 might not be enough. You need at least 100 of patients of that same pathology, of that. So for you to match a a prototype, like, or a phenotype, you have to have as much, you have to have like a wide net. So I think that's an important step. I'm
Mhm.
not sure how it's going to start, because first you have, let's say, data safety, patient HIPAA, you have who's going to share the data, how is it going to be interpreted. um, Methodology analysis differs between centers. Like, people see things differently, people want to analyze things differently, that might create a discordance, that, and the project stops. So all these things, I think, probably societies like the Epilepsy Society or AAN, if they come with an umbrella agreements with other societies overseas, and say, okay, those are the collaborative works we're doing, and this is a group that studies this, that might be something that would be great as a start, and could have certain guidelines, points. For example, let's say this is your delegation of tasks, like what you need to do, you have to abide by this, and then someone, an independent committee, oversees the the workflow, the operational workflow between this. And I think once that becomes standardized, like people learn it for 10 years to do that way, I think it will become automatic.
Yeah, I mean, yeah, this is the tough job of a bunch of PIs and co-PIs to lead this project. I was in China not too long ago. There's a hospital called the Sambo Hospital in Beijing. They do approximately 100 SEEG implantations per year. So yeah, there could be wealth of data, in other international sites as well. I have two quick questions. We're approaching 9 o'clock. That I think are relevant to a lot of clinicians. First, uh, this is something that we probably have some answers about. How does the circadian rhythm between sleep and wakefulness influence the HFOs physiologically and pathologically? And second, I'm gonna I'm gonna ask the second now because it's my last question. How do medications influence the characteristics of HFO? I mean, and this is something we see in the epilepsy monitor unit before and after discontinuation of medications to facilitate monitoring and so forth. So medications and sleep.
So first of all, coming to medications. So medication, the effect that has been described on HFO is unlike the spikes. So HFOs are earlier. So medications, Gottman's paper, I think they said that for spikes, not HFOs. Medication does not necessarily impact it. It's after the seizures, and you see that. However, the HFOs are a bit different. In our data, we're seeing it differently when we're analyzing our networks. We do see a high impact of the medications on the HFO. However, that has a caveat. You're coming out of the intraoperative phase where you have snowed the brain with sedation and anesthesia. So is that impacting? That's true. There is research on that. There isn't the data on that. But the question is, if that impacted, which HFOs are coming up? Is there a specific sequence are showing up early on as you're coming out of anesthesia? And then the second is that the other limitation, you're through the intracranial monitoring. Yes, you're lowering medications, but you're also getting to a seizure phase. You're preparing your brain to have a seizure. So that's another variable to it, another layer to it. I think seizure medications and seizures with the intraoperative phase has to be all sort of, we have to analyze it with a high sample number. So small sample number is not going to give you a good one. And then the other caveat is, which I've seen it actually, the sequences or of the networks of the HFOs differ at the last day. You have a lot of them, and especially after stimulation. So when you're doing extraoperative stimulation, 1 hertz or the 50 hertz or the mapping or so, there is a different set of sequences coming up. The whole brain is sort of like lighting up with sequence. So what does that mean? What does that imply? Like you triggered the brain, or the brain is exhausted. Now you have all these sequences. So that needs also additional analysis. There has been a group who looked at the stimulation triggering and eliciting HFOs in Netherlands. So there's that way. As for the seizure, the sleep and HFOs, you see it more in the non-REM than the REM, than the awake phase. I think the limitation with the awake is you have lots of muscle artifacts. So it becomes hard for you to tease out those HFOs. In the awake phase, you should have technically the physiologic ones, technically, because you're doing lots of activities, thinking, seeing, memorizing.
Yeah, well, memory consolidation occurs during sleep, obviously, right?
That's very true. That's very true. However, you also have in the sleep the pathological ones showing up, right? So there have been data that showed that when you have seizures coming up, physiologic data gets suppressed. And does that happen still equally at night or not? I'm not sure about that. But in the evening, definitely in the non-REM stage, you have a lot of variations that you will see in the HFO. That's why they say you can use multiple short segments of 5 minutes during the night. When I show that slide, they show that even within a single evening, within 1 hour, you will have different rates of HFO at different timing. Why does that happen? I'm not sure.
Well, thank you so much. That was wonderful, Aline.
Thank you for the invitation.
It's been our pleasure. Next week we have another Yale professor.
You're running the Yale Club now.
Yes, consecutively. So we'll see you next week with a talk on neuroimmunology, by Dr. Hafler.
Thank you so much. Have a nice day, everyone. Bye-bye.
Everyone. Bye-bye.
Thank you.